Up next is a panel discussion on how will the ART transform the IVF segment. The panel will discuss how Assisted Reproductive Technology Regulation Act is going to shape and help both the doctors' fraternity and the patients. I would like to invite Advocate Dr. Sonali Kusum, Assistant Professor of Law, Tata Institute of Social Sciences, to lead the conversation. Welcome, Dr. Kusum. The panelists are Dr. Sonia Malik, Program Director, Southend Fertility and IVF Centers; Dr. Nandita
Palshetkar,
President-elect ISAR; Dr. Firuzah Parikh, Director, Department of Assisted Reproduction, Jaslok Hospital and Research Center; Dr.
Hrishikesh,
Pai, President-elect FOGSI. Welcome, everyone.
Hello and welcome all to the ET Health World Fertility Conclave 2022. Today we will be discussing a very important topic, how it's going to transform the IVF segment. We'll also look into the role of ART banks, ART clinics, the issues of biomedical ethical compliance, the patient care, issues related to penalties on the clinics. So let's hear about these from our esteemed panelist. The word ART has been defined. Now, there is a seeking probe into this, whether IUI treatments and other medical treatments of similar nature, can this be included in the term ART? I would like to first pose this question to Dr. Hrishikesh Pai, and then we can move subsequently to the other panelists as well.
Hi, hello. I'm really happy to be there on the panel today. And as you can see, intrauterine insemination, you take the sample, you process it in the laboratory, and then you insert it into the patient. So because there is a manipulation involved outside the body, any clinic, you stimulate a patient and then send it to an IVF center or a IUS level 1, 2, 3 center, and they do the procedure. Then the person who stimulates the person doesn't come in. So this is a mechanism wherein you have to decide. If you look at our gynecological fraternity, there are 38,000 gynecologists. So not all of them is going to do it. Only maybe 3,000-4,000 who are running their ART or IVF clinics may do it. Rest of them can stimulate, counsel the patient, stimulate the patient, but for the procedure, they can send it to the particular clinic which comes on, follow all these compliances.
Thanks. I would like to also extend this question to Dr. Parikh if she wants to add anything to this.
First of all, thank you, Sonali, for having me on this very important deliberation and discussion. By definition, IUI is not included in ART. I'm talking about by scientific definition. But as Dr. Pai mentioned, it is very important at this point to include it in the other things that we have in ART, because IUI is only a precursor to IVF. Should IUI not work, the next step will be to move on to IVF. So yes.
Thank you. Dr. Sonia, Malik, I would like to know from you, what are the other kind of similar treatments that I was mentioning?
Thank you once again. I would also like to thank you and Pratibha as well for having us here today. It is a very important panel and a discussion which I hope will come out with some kind of outcome. But anyway, this question that you've addressed to me, it means that you have to have the handling of the gamete outside the body of the woman. And as such, beyond, unless you are putting in a neat sample into the vagina, which some people do, a direct insemination into the vagina or into the cervix. So any manipulation of the semen, which goes into the woman artificially by some artificial means, which is handled by the doctor. But as Dr. Parikh said, these are all extensions and they are a prelude to IVF, I would say. So first we are doing these as the first step, and then if it doesn't work, we go on to IVF. Therefore, as Dr. Hrishikesh Pai has said, it would be good if the gynecologists understand this and, they register under the ART clinic as an ART clinic rather than doing these things without getting registered. It would be helpful if they register.
Dr. Nandita, I just want to know from you. Now, since Dr. Firuzah said that scientifically it is different, but legally now it comes in under the same umbrella, do you think it will be fine with the medical practitioners?
I think from our side is to educate, spread awareness, like what we're doing today. We have to tell our colleagues, our gynecologists, that, okay, these are the things that need registration. See, we all follow the PCPNDT and the MTP Act, and we fill forms and we do everything properly because it's an act, it's a law of the country. Nobody wants to break the law. So I think this information, that what you can do and what you cannot do, is something that FOGSI will have to take up, the government will have to take up, media will have to take up, so that we educate our masses, our doctors, that this is something which you must, register for. Another, group which really comes under this ambit is even general physicians. Like supposing a couple is having a problem, even having sex. So they just tell, okay, remove your semen and take it with a syringe and put it inside. I mean, so all these things, if it's done in a clinic, again, these things will really have to be clarified. What exactly we can allow in the clinic. As Dr. Malik has also said, this also will not be allowed. So it's important to inform them, because registration, everybody may not want to register and maintain the records. You have to maintain records when you're registered and doing a procedure which is under the Act. So I think this information needs to really be spread, and we will do a lot of CMEs. We will hold a lot of, Zoom meetings where we inform our people what exactly has to be done.
So just a point which I think we forgot. There are lots of gynecologists who are asking pathologists to actually, prepare the sample and then send it across to their clinics. So I suppose even those pathologists are going to be registered, because they too are handling the gametes. Just as we are doing it for the PCP and DT, I send the gynecologist to these groups as well, because anybody who's handling these gametes, and sperm is something which lots more are handling rather than the oocyte. So probably we'll have to do it.
Thank you for that comprehensive information. I think it's very, very important that the word passes out, that pathologists as well as the clinics and all these units, gynecologists, has to register. Now, coming to another question, I am glad that Dr. Nandita brought it. Registration of the ART banks as well as the ART clinics has been legally very much prescribed and mandatory. So I would like to know from you all that as medical practitioners, experts in this field, how do you see the procedure of registration which is prescribed? Does it make the practice of ART technologies, which is so much in demand right now, to the patients and to the couples easier? Or is it restrictive? How do you see it? Yeah, can we please start again with Dr. Pai, and then we can move subsequently to the panelists.
We are already now well-versed with the PCPNDT Act. So we are already, sort of acts are there in the gynecological field. Unlike my other colleagues in other fields, sometimes I wish I was not a gynec. I should have been an orthopedic surgeon. Whether they have no, we have already come under the PCPNDT Act, and this act we are very compliant. In fact, so compliant that our sex ratio has changed now. There are more females than males.
Yes.
So we are very cool about it. The AMOs are cool. The state bodies now know how to implement the act. They come once a month and they look at our records. You understand, whenever we are registering, we have to we make the agreements and we tell the state board and they automatically give. So everything is in place. Only the government will have to have a state board, a central board, a registry. So infrastructure has to be increased. That is going to be a problem. But I don't foresee anything, because already the PCPNDT Act has laid the grounds for a smooth application of the Act. And I would like to tell you that the medical fraternity is very, very intelligent and very compliant with the Act. We are white-collared people, so we don't like to break any rules and regulations of the law of the land. So I don't think there should be a problem from that angle. And we will definitely be very cooperative with the government in effective implementation of that.
Thank you. Can you please also hear from Dr. Sonia, Malik? As there has been this issue related to this question, that so many clinics have come up over the years, because Earlier, the position was ICMR had some guidelines, and ICMR was functioning as the nodal agency to implement all the guidelines with respect to regulation of the clinics, control or check the malpractices in the sudden growth of all these ERT clinics.
I think it will. I think it will. It is a very stringent kind of any chances, and we have already, like Rishi has just now said, we are already very compliant and we are very used to the PCPNDT Act now, and we are actually fulfilling all the criteria that is required for the PCPNDT. And so this is just an extension of what has been done. For us, it may not matter much, but for the new person who's going to enter, he'll have to think twice before he starts registering for a place like this. And definitely it will check people who are not well trained in the field, because basically now we have to report so many things to the government, and registration and re-registration and facing the national board, the state board, the registration authority, and all that is going to be a deterrent for people who are not used to following the rules, and probably are not very well trained also. So it is definitely going to help people who are doing good practice. It will help.
Thank you. Dr. Parikh, I have also a very related question to this. While we are saying that the registration procedure is watertight and it's also strict, very mandatory, it is good, it is checking the unnecessary and those who are indulging in malpractices. But if the registration procedure is very watertight and, then will it not increase the burden, or will it not restrict the, or will it increase the cost? Because as Dr. Pai was mentioning, it will require infrastructure, it will require manpower to comply with all kind of regulations. Then, like, adversely, does it not increase the cost of the ERT clinics treatments, and therefore it may become cumbersome for the couples and the patients to avail treatment?
Sonali, I have a view on this, and in this time, what the health ministry should have done is we have about more than 2,500 clinics all over India. I think that is maybe even more than that. What the ministry should have done is first contact the 100 topmost clinics. Topmost in the sense that they have a patient load, they are registered with ICMR, they are following all the rules. Taken them into confidence. See what is the ground reality. See what are the problems these existing clinics are already facing. Okay? Find out what difficulties they're having with patients. Even doctors get exploited by patients. Even doctors get exploited by so many institutes who come to them, auditing them, or say you want a certificate for not only registration, to show that you're following all the rules. There are so many audits that occur. So I think this is the time for doctors and the government to have a marriage of the mind. Okay, where we express our concerns, our difficulties, and we have representatives of our bodies. Maybe the bill is passed, maybe the law is passed, but it is always there. It can always be rectified to suit some of our needs, and all of us will be compliant. There is no doubt in that. But we have to have an easy path. We don't want to increase the financial burden on patients. Obviously, if this means auditing, if this means more paperwork, the cost will go on to the patient, or the cost will partly be taken up by the hospital, by the clinic, but ultimately it will be the patient who will not benefit.
There is inspection proposed by the national board, state board, as well as by the National Registration Authority. Then how do we see, how does it facilitate? Does it not include like too much procedural burden on the clinics, or will it also be causing duplicity? Because which records are to be placed before which authorities, or is it the same? Yes.
I think whenever there's a law and there's a compliance of legislation, the inspection becomes a part of it. I mean, we have to accept it and go along with it. We must remember that as gynecologists, as Dr. Pai said, that we have the most laws against us, but we are treating women. Women are the most undertrodden in this world. And that is why there are so many laws to protect them, to kind of elevate them, and to, give them a better chance so that we attain gender neutrality as such. So if we look at these inspections, we have to look at them very, holistically. These inspections are so that your center functions to the utmost, quality. All the inspections, as our association, I mean, we've had Firuzah has been a president, Hrishikesh has been a president of the Indian Association of ISAR, Indian Society of Assisted Reproduction. I will be taking over in March, and Sonia has also been a president of the Indian Fertility Society. Through our societies, we have formed accreditation, of the clinics. And in fact, this was a time when Dr. Pai and myself formed these accreditation. Inspections are done by our people, and all these were following the ICMR guidelines which were set, because this law was actually, the whole thing started in 2003 2004. So we got this into our association, and most of the clinics are accredited by our association, so they are used to inspection. And I think this inspection procedure is probably required, will be done. And now with the pandemic challenged virtual world, they're doing even online inspections. We are doing it through our associations for a lot of things. So, we will use technology, we will apply it. I just hope that it is the same across the board. That something like how we had to fight PCPNDT because the local authorities were saying something, the state authorities are saying something, and the central is saying something. So I think we are going to work as a body together so that the same uniform guidelines are kept throughout all the three, parts, the state, the local, and the center. I think that is what we should look for. And inspection is going to be part of our lives, so we have to put up with it.
Whatever is said has to be at all levels, and it should be so watertight that no officer can change it. What is happening today with the PCPNDT is, because of the ambiguity of the law, there are umpteen number of interpretations of that law, and hence it causes problems at various levels, state level, district level, etc. So that shouldn't happen with this. Otherwise, it is going to create a lot of problem for all of us.
With respect to the functioning of the ART bank and the ART clinic, so how do you see it? The functioning of the ART banks vis-a-vis the ART clinics. Also, are these two entities going to be under the same? Yes. Can we have Dr. Sonia, Malik, please, to answer this first?
Well, it is very clearly mentioned in this bill that they are going to be different entities.
I personally feel that, if you look at it from the operational point of view, the pickup, because in the egg donor, there is a surgical intervention involved, there's an anesthesia which is involved, and I think there's a lot of safety issues. But I think the ART bank should, as far as the women are concerned, should maybe do the administrative part of recruitment, screening part, but the actual procedural part should be done in the clinics only, because we have to think about donor safety and all, and the clinics are well versed. Last 30 years we are doing oocyte retrieval. What if something goes wrong to the donor? So we have to do the surgical part in the ART clinics. Maybe the administrative part and maintenance of records, screening, anonymity, follow-up, agreements with the donors, counseling of the donors, all that can be taken care by the ART bank. And secondly, if you freeze the oocytes in the ART banks and then you send them, you're putting two additional steps: freezing of the eggs, then thawing the eggs, transportation of eggs, cost will go up. Additional steps will go up, so I feel that from the practical point of view, this would be a better scenario where they just do the administration part and the surgical part and the storage part is done by the clinics. So there is no duplication of infrastructure. See, India is a poor country, and what is our aim? To reach the remotest of everything. Whatever resource we use up for something, the other somewhere else someone will suffer. So we have to be more balanced in our approach. We are not a small country like Australia, 30 million people. We are a 1.3 billion people country. We have to look at it at a larger, holistic way.
So,
thank you, Dr. Pai. Yeah, Dr. Firuzah,
can I just respond to one of the things here? I think calling it an ART bank is a misnomer. Because when you say bank, it means storage. Okay, in banks you store your money, right? You have safety deposit vaults. I'm just adding to this, that then we cannot call these ART banks. They have to be named in a way so there is no ambiguity. Basically, if these are going to just supply, then they are like recruitment agencies. They are not a bank. So we have to also make sure that the government understands this terminology. It's very important to understand the terminology. If we are going to be doing the pickup or the egg retrieval, what is the role of the bank then? Why should they then be screening donors? How can we be certain of the screening? If the name of the donor is not revealed to us, if we don't know whether the donor has had cycles before, if we don't go into the history, we have patients or donors who we have refused because they had autistic children, which would not have been revealed if we didn't counsel the donors and go into the history. For every donor that we screen, we do a clinical exome, we do the fragile X, we do the karyotyping. All right? Will the ART bank promise to do all this? Will we have all those reports? Will there be credibility? So there are a lot of things that we have to discuss with the government regarding these fine nuances, which can have an impact on the couple's future progeny.
Yeah, I was coming to you, Dr. Nandita.
Yeah.
Please go ahead.
No, regarding that only, that see, if that ART bank has a retrieval process, has a lab in which to do a pickup, has a storage facility, why will they not convert it into an IVF center? You know, they have.
That's my question. Like, should the ART banks and the ART clinics be separately located, like Dr. Pai was saying and Dr. Sonia Malik was saying, that it has to be separate entities then?
Yeah, but that's what I'm trying to tell you, that, okay, these are the functions that are given to the ART bank and to the ART clinic. But the bank, in order to give us eggs, has to have a lab, has to have the procedure to remove the eggs, has to have storage where they freeze, embryologists who are trained for all that. So all that expenditure, why will they not start an IVF center? So at the end, we may have a problem that there are no ART banks and there are just IVF centers. So I think we really need to, kind of define the work.
If you look at the statistics, it's only 30% of the infertile couple who are actually in any center who is doing good work. You're not doing more than 30% of the cycles as donor cycles. The rest of them are self cycles. And here somewhere we are forgetting the self. We are forgetting the actual patients, the infertile couple as such. We are only more worried about third party in this act, either the donor or the surrogate. So unfortunately, for those, we are spending so much of our energy trying to figure out and trying to understand how we can perfect this method of doing a donor cycle well and of doing a surrogacy cycle well, where it is just about 30% or 20%. But the rest of it needs to be really ironed out, and that needs to be done properly. No mixing of gametes, ethical practices, all that needs to be emphasized. And Nandita has said very rightly, if they are to be doing everything, then what is the use of having it? They will become IVF centers only.
There's another point, Sonali, miss, we are also doing a lot of fertility preservation. We do egg freezing for fertility preservation. We do egg freezing for cancer. All of us are doing cancer preservation, pre-cancer therapy. So all that storage has to be with us. Otherwise, they'll say, okay, now see what Dr. Firuzah said was correct. The terminology bank is a wrong terminology, because now they'll say, okay, then even fertility preservation, you go to the bank and store your eggs. So there is a lot of ambiguity which is there, which has to be sorted out. We do a lot of freezing of husband samples also. Why will we send them to the bank for storage? We have our internal storage, and as I remember, in the older guidelines, self-storage for patients and husband and embryo freezing storage all has to be within the IVF clinic. But that has to be demarcated properly. Otherwise, there will be confusion somewhere.
So do you all suggest that the functioning of ART bank, ART clinics, should they have some kind of a contract, or if not contract, but some kind of written agreements or MOUs? How do you see the functioning to be recorded in writing for the ART banks and the ART clinics? Do you suggest that the ART bank and the ART clinics should maintain their own agreements or MOUs when they are dealing with the ART banks? How do you see that? So could we have Dr. Hrishikesh Pai address that first?
So we already have contracts. So all our patients, agencies that who give us the donors and all that, we already have written contracts with them. So as we are very, all of the people who are in this forum, they are very foresighted. We already are compliant with the ART bill. All the rules and regulations we are already following in our bank. So in our setups, so we already have written contracts. So because we have to, otherwise tomorrow if there's some problem, the recruiting agency does, we should not be liable. Na? See, we are, as Dr. Firuzah had told just now, we are relying on them that they are doing. Suppose they don't do it properly, then what will happen? So we have to have written contracts and agreement. In fact, at the present moment, with our donors, I have made them compulsory that they have to have a affidavit in front from the court, so that there is no discrepancy. Tomorrow donor will say, "Oh, I was not told this. Oh, I was not done counseled properly." So the affidavit is a given. I am not going to practice any third party option unless there's a written affidavit from the third party in the future.
Thank you for suggesting that. Dr. Sonia, Malik, what would you suggest? Because a lot of clinics who are getting into this in the banks, what kind of paper check or documentation they should maintain? Like Dr. Hrishikesh Pai was suggesting affidavits, then having contracts. What would you suggest about it?
Again, yes, like he said, we are all very compliant. All of us over here are actually following the rules to the hilt and following the ICMR guidelines like anything. So in the ICMR guidelines, there are already these contracts which have been given as examples, and we follow that. We tell the agencies to just download the forms from the ICMR guideline booklet and then use them as, affidavits for any third party. So the other thing is that I would go a step further. If it is a self cycle also, many a times these people come and tell us they are married, but they may not be married. So we are actually going to that extent also, getting an affidavit from them also, if they, to prove that if we find that it is a little suspicious and we feel that, this person may not be telling the truth, we tell them to get an affidavit from the court to say that they are married before we take that up. And I believe some of the clinics do it as a rule. So that also will have to be done, because basically you don't know what is going on in the mind of people.
Thank you. Dr. Nandita, would you suggest some best practices or some kind of documentation between the ART banks and the ART clinics?
I think it's been very nicely put in the law, that the donor, these are the tests that should be done, or if it's a surrogate, this is what should be done, what are the rights of the donor, what medications, everything. And I think they've just gone a little bit too far by saying that many number of eggs and all that. But it kind of gives you gives the unit an indication that you should not hyperstimulate the patient. So even though the thought process was very good, it's not implemented, in the correct sense. So we need to rectify that and, in the rules, talk about what to do with the eggs and all. But today, as the law stands, whatever is been there, what we have seen has actually what is required for the patient. I think every year there were different people on the committee of this making the law, and there were multiple meetings. I was there for some time, Dr. Pai, Dr. Sonia, Dr. Firuzah, everybody has been on that committee. And we have put in a lot of steps, a lot of precautions so that there are no problems. Like as Firuzah said, the donor needs to be evaluated properly. So all those things will have to be put in, that we want these tests. And as the science is advancing, we need to keep that little open-ended, that we should be permitted to do the tests as and when they become available, and they are, not very expensive. So I think these points are very important when it comes to the understanding between the ART bank and the clinic. Now, even when we do surrogacy, we also, it comes from a surrogacy agency. So there are certain guidelines. We want the surrogate to be this year's. We're following the guidelines which were set, kind of. So I think that is very, very important. There has to be these kind of caveats to tell the ART center, as well as there are caveats for the ART center. There have to be caveats for the ART bank also.
Dr. Parikh, quickly, could you also add some of the points as to what would you suggest with respect to functioning of ART banks and ART clinics, like any documentation, further checks?
I am totally confused about ART bank and ART clinic. I really don't know how we are going to progress. Why I'll tell you. Sometimes I wonder, now in our clinic, and I'm sure in everybody's clinics, we have already got a lot of eggs in storage from donors, okay? Because donors give us 20 eggs, 30 eggs. So what am I going to do with those eggs when the government says that now you have to take from the ART bank only? Am I going to destroy all those eggs? So honestly, I don't know how to answer your question because I am confused. I have no answers to myself. We have all the SOPs, our SOPs at Jaslok go into 600 pages plus. So every procedure that we do, every lab equipment that we use, we have procedures. Now, who is going to sit and make all those SOPs for the ART bank? Is the ART bank person who's heading it going to be an embryologist, an IVF person, a technologist, a bureaucrat, or a businessman who has money to spend on an ART bank? Who is going to lead that operation? How is science going to progress? So honestly, I don't know how to answer your question.
Sonali, what is going to happen is that, but like what happened in the MTP Act now, the modification has been done. So once the rules will come into place, then after 1-2 years, there'll be a review probably, and we'll have to modify. So it is a dynamic thing, and it will take many years for it to get streamlined and get ideally implemented. Just like the PNDT Act came in, I think 87, I'm not sure, 87 or 91 or whatever. But now it has ideally implemented. And so I think we should take enough time for implementation.
So I would like to know from you all, how do you see this compliance with biomedical ethics, counseling, especially counseling in our country? As we all know, people are largely unaware of the laws, rules, regulations, or medical technologies. So do you think the provisions on counseling and the provisions on the written informed consent, is it adequate or is it going to help the patients? Yes. Can we begin with Dr. Pai, please?
We are quite good at our counseling now. Informed consent is taken. In fact, the language of the patient is also very important. And my vision as FOGSI president, I'm taking over as FOGSI president, is to create video counseling for everything. So there is no ambiguity. So tomorrow you have a cesarean section, the video counseling will be done. Our committee will make a nice video film of 20 minutes telling you about the pluses, minuses of having a cesarean or not. They see the video and they sign. So we have to use digital media in the future. What has the COVID taught us for the last 2 years? We have become digital. See, we are all sitting here. I feel as if I'm sitting in a room and conversing with you. So that is what is the new mantra, the digitalization of life. And so the counseling has to be totally automated. In fact, all counseling, all consenting, everything, I want to make it digital. So there is no ambiguity and there is no controversy only. Once they see the video and they sign it digitally only, that's it.
That's a good suggestion to make it digital. Yes, Dr. Sonia, Malik, what would you like to say to that?
See, we were already doing it. Actually, in the ICMR guidelines, you're supposed to have a counselor, an infertility counselor in every clinic. So we do already have a counselor who counsels the patients on each aspect, on the medicine, on the medical aspect, as well as on the consents, as well as on the procedures, the financial aspect. Everything is counseled, by the counselor and by the doctors themselves. We actually do very little procedures. We are mainly counseling our patients most of the time because infertility requires a lot of counseling, therefore, I don't think this is going to make much of a difference to our practices because we are used to it, as Dr. Hrishikesh says. And like he said, if it is going to become automated and, we are going to have these kind of digitalization of consents as well as counseling, it will make our life much more simpler. But given that, even if you show them a video, even if you sit and tell them, they will still come back to the doctor sahab and say, Doctor, ye baat samajh nahi aaya, please phir se samjhaoge, and maybe at the middle of, say, 8 o'clock at night when you're having your dinner, they will ring up and ask one question, which according to them is very important, but it is completely silly for us. But that is acceptable. We know that is going to happen.
When you're saying that counseling and written informed consent, whose liability will it be more, of the ART bank and the ART clinics, or both of them?
I think we all are doing it. We have all these elaborate consents. And as Dr. Sonia said, when I sit with a patient, I'm the counselor, actually. Our Indian patients, they think counseling, they think we are mad or what? Why are you sending us for counseling? Actually, they don't understand the concept. It's okay in cities, where we are practicing now, people are tuned to it, and we are sending them to counselors and we are doing it. But look at the places, like we want this treatment to reach all over our country. If we have to reach the remotest places, they have to have educated counselors, etc., etc. I think we are going to have a need for infertility counselors. They have to increase because we're making it compulsory. The law says they have to be independent from the clinic. So all this is going to necessitate a whole, you need these qualified people to be available so that they can get attached to the center. And the doctor, at the moment, I'm telling you, we doctors spend so much time with the patient. It's more about counseling. It's not, the treatment is very simple. Ye injection le lo, we'll do the pickup, we'll get the eggs and we'll put it into you. But that rest 25 minutes is spent on talking to them, telling them, asking them how they feel about it. So I think it's the responsibility of the clinic where the patient is concerned. Now, if the donor is going to undergo a pickup with us, then I personally feel the ART bank should do all the counseling, everything, and submit those papers to us that they have undergone all this counseling, and because that will be one of the requirements to get a donor into the program.
Dr. Parikh, would you like to add anything to that?
So, Sonali, to address your question about counseling, we found out that the comorbidity in couples with depression, with feeling of lack of self-worth, was very high, as much as 30% to 60% in some groups. Okay, the longer the infertility, the more issues they had with psychological comorbidity. And what we have started implementing, thanks to Rajesh, we have two very sweet looking and young psychologists who first introduce themselves to the couple before we start, okay? And they take a history, they spend about 45 minutes. And believe me, they go into the real world issues that the couple is facing. Once that is done, then we take over. And the psychologist comes and tells us, look, these are the issues that we have identified. And that really helps us to get along better, to understand the couple better. So many times you're faced with a problem where the couples have not consummated the marriage, but they will not reveal this to us. They feel that it's something wrong that they're doing, that they're not able to have sex, okay? It's a real fear, but they will not open to us, but they will open up to somebody who's trained in personal counseling, somebody who knows the questions to ask. What we will do, we will say, okay, how many times in a week do you have sex? Is the couple at the first visit going to tell us that, look, doctor, we are here because we cannot have sex, okay? Or my husband has a problem with sex. So I think, at least in our center, what we do is the psychologist very nicely takes a detailed history, becomes a friend to the couple, then sends us their background check in the sense what is anticipated, and then we start with her. That makes my job and my team's job a little easier because we already know the psychological impacts that are going on in the couple's life.
My only worry with this counseling thing is we are here, all of us are running private infertility clinics. And when we are talking of infertility reaching the masses, we are looking at the public enterprises as well, those in the medical college. And if you look at the quantum of work that they have, the number of OPD patients that they have, even in infertility, then I don't know whether they'll be able to justify this kind of counseling of 45 minutes for each patient, because the OPD will run till 12 o'clock at night only doing counseling. So that is something that will really have to be considered, because our workload in India is much more than what it is in the West.
So far, there have been so many issues that the ART clinics or the ART banks are misusing, they're exploiting couples, third parties. There will be a national registration authority which will look into the complaint, give an opportunity of hearing to the clinic, and then resolve the complaint in the grievance. So how do you see this as, will it help the patients? Will it help the third parties? And how do you see it, this entire grievance redressal procedure impacting the ART clinics or the banks? Yes, can we have Dr. Pai to address this first?
I think we should reverse the order. So I feel that the doctor-patient relationship is very important and we should be positive about it. So complaint should not be emphasized. See, because this line is which is the line in medicine which has got 30 and 35% live birth rate per transfer. It's a that way comparatively low live birth rate compared to, if you say bypass, angioplasty, knee joint replacement, everything is 95% plus. So obviously, suppose there are 10 people and 3 become pregnant and remaining 7 don't become pregnant, they are going to be unhappy. So counseling, of course, is very important for us to tell them that the success rate is 1 in 3. All that has to be done. So counseling is very important, but still the complaint. So remember, the complaint, people will be more prone to complain not because of anything else, but because they fail to become pregnant. They become a bit, unhappy about it. So remember, we want this movement to thrive. Ultimate objective is what? To have a baby for that infertile couple. So the complaint, the protection, if you don't give the doctors enough protection, people will stop coming into the line. You understand? So we have to be balanced in our approach to complaints. Medical complications should not come under the purview of this act. It is the ethical infringement, like donor recruitment, surrogacy recruitment, or you did a treatment for man over the age of 55. Those are ethical. You did a sex selection. These are ethical infringement. This act is for ethical infringement, not for medical complication. Similarly, I personally feel if there is any issue of complaint, this should not come under the purview of this act. That should go under the standard complaint. If there's a patient who says that Dr. Pai didn't do my thing rightly, he can go to medical council and complain. Why should it come under this? Because what will happen? You will kill the movement. If you start implementing like this, no one will come and do the infertility treatment. All patients will have to go to Middle East and Far East to do the treatment. We don't want that.
Dr. Firuzah, Parikh, what would you like to say about this? You find when Dr. Pai was speaking, you were finding it very amusing. So I thought you have some similar views.
No, I completely respect and appreciate Hrishikesh's point of view, and I agree with him 100%. There are a lot of studies done which have shown that 90% of the cases where patients sue the doctor is because of miscommunication, or the doctor being harsh, not communicating. There is no other reason. So many a times, if there is very clear communication, like how Hrishikesh said that you have a video which shows this consent, your interaction with the patient will prevent a lot of miscommunication and will definitely not make the patient sue you or bring about a legal process. So it just doesn't stop with a bill or an act which may be 100 pages or 50 pages. We have to give a lot of attention to these nuances, because as Hrishikesh said, this act will dissuade our youngsters from taking up IVF.
In India, we have 26 million deliveries a year. You understand? Yeah. So we cannot. So, Sonali, please understand. And this has a lot of women's health activists have to understand that. And it is your duty to communicate this to them. That look at the overall movement. Our maternal mortality has come down. You may listen to few complaints, but majority of the people, there is an amicability between the doctor and the patient. Already there is a good amicability. Let us not say that there is not much strife. How many complaints are you seeing in the? So let us not create a problem when there is no problem. Let us integrate medicine. See how we can improve. Be positive. For that, you need to give positive inputs to the healthcare workers. You need to tell them, no, don't worry. We are there to protect you. We need you. Look at the COVID shortage, what is we are facing. We need the healthcare workers. No one even will come into a medicine. They'll say, what is this COVID and all? We have to do COVID warrior duty and all that. So already the people are scared. So we have to give them the sense of protection, the sense of belonging. That is what is important. Amicability is important.
Dr. Nandita, quickly coming to you, would you also agree that Should it be, centralized, one kind of a process, no further complaint?
See, I work in a medical college also. And there are kids who want to take up, like cosmetology, radiology. They don't want to have a life of a gynecologist where we are on duty 24/7. People can deliver anytime. We are going to have that paucity otherwise of the doctors. And by the way, now it's 30 million deliveries per year. So that is what we are looking at. And if you don't have gynacs for this particular work, I mean, it's going to be very tough. So I think we have to think of the other side of the coin also.
If there is a non ethical dispute, so then there should be a grievance cell. I have no problem. But the grievance cell, if at all the patient doesn't agree to the grievance cell explanation and he wants to dispute it, it should go to the standard arbitration council or the consumer court rather than it's under purview of the act.
In the formation of the national board and the state boards, the representation of the IVF specialist is not there. They have mentioned that not even a gynecologist in one of the boards, but it is generally in the registration authority. It's a registered medical practitioner. What does a registered medical practitioner is the only medical person in that registration authority. How can somebody who is just a registered medical practitioner register an IVF clinic is something, or an ART clinic is something which needs to be looked into very, very seriously. And also the formation of the boards. They've written gynecologist, but not an IVF specialist anywhere. So that is, and then if they have to sort out our grievances, it is going to be a little tough for us. It might become a little difficult.
The punishments will be there on the ART banks and the clinics, even on the medical practitioners, ART practitioners, for any misuse or exploitation of the surrogate or the donors, third parties or the couples, or misuse of the technology itself. And the punishment is very stringent, ranging from 5 years to 10 years of imprisonment and fines up to the amount of 10 lakh to 25 lakhs. So how do you see this punishment or penalty? Do you see it as a very stringent one? Considering it is a life-giving practice, there should have been a presumption of good faith, because medical practice, I think, comes from the idea that it is being conducted from a good faith proposition. So how do you see that? Dr. Nandita, let's hear from you first.
I think, the whole tenor in this whole conversation has been that the punishment, if it is, we violate the ethical problems, like doing an IVF for a man who's more than 55 years old or a woman who's more than 50 years old, misusing. I think that should be clarified, that the punishment is too much. Of course, that's what I personally feel also. And it should be for the ethical infringement of the law. This should be well clarified, that not for medical complications, as we've mentioned before. I think that is what I would really like to, reiterate again and again.
We do not know what exactly would mean by exploitation of third party or exploitation of couple. Like, that term can be interpreted in so many different ways, and possibly like misuse. What kind of misuse, and is the term misuse being very exhaustively used, that these things are misuses? So how do you see this impacting the ART banks and clinics? Yes, Dr. Sonia. Again, we come back to ambiguity. Again, it'll have to be defined in very clear terms. And that is exactly what we are trying to say, ethical and medical. It has to be clear. We have to demarcate it into two parts very, very clearly. And when you come to the ethics part of it, yes, what you are saying is, exploitation is ethics. When you're exploiting them, you're exploiting something which is, you're exploiting them maybe financially, or maybe because, their feelings, or you haven't told them properly, or whatever. So all that has to be taken up by these punishments, as is stated over here. And the rest of it, of course, will be decided by the medical council or whoever is taking up the grievances. And that would be standard statutory punishments which are already existing for us in the other fields.
So in this, like, in PNDT also we are used to this kind of a harsh punishment, and it was in fact initially non-bailable offense once you are caught with something, but it has gradually over a period of years, like Dr. Hrishikesh has said, gradually it has softened, and now it is not a bail, it is bailable. You cannot be arrested for it. So similarly over here, I think with time, or once we are able to thrash out the problems that we are going to face with this ART bill, we may be able to, define it in a much better fashion and then grade the punishment. You cannot have such a harsh punishment coming at a most trivial point. Say, suppose you haven't made correct entries into the registry, or you haven't reported your data properly. There have been mistakes in that. You cannot be your accountability cannot suffer because of that. It is a mistake. It is a clerical mistake or a computer mistake which has happened. So you can't be held responsible for something like that. So it will have to be eventually graded, just as we have in the PCP-NDT.
With the coming in of Ayushman Bharat, how do you see the scope of ART technologies, including IVF or surrogacy? How do you see these to be included under Ayushman Bharat? So can we please have Dr. Hrishikesh Pai to address this first?
Ayushman Bharat, there is a lot of schemes now. The Federation, I'm the president-elect of the FOGSI, Federation of Gynec Societies of India. We have been asked by the Ayushman Bharat people to furnish our charges for various gynec procedures like delivery, cesarean, hysterectomy and all. So I feel that we should also bring IVF under the purview of the Ayushman Bharat scheme, because I think that access to care is a very important part, and infertility is a very important part of life.
Therefore, if we have to look at the smaller towns and the villages where we want this whole thing to reach, then definitely we will have to consider schemes like Ayushman Bharat, because patients in those areas, remote areas, cannot afford this kind of, charges. And as we have all been discussing, the charges are in any case going to go up with so many things being included into it. So if we are looking at all this, yes, the government should include it in Ayushman Bharat. It will definitely help lots of people.
So I'll come to Dr. Firuzah Parikh for her comments and then go to Dr. Nandita. Yes.
I second whatever has been said by Sonia and Hrishikesh. I think it makes a lot of sense to let this proliferate in the other areas of India also. So I second whatever they have said. I have nothing more to add to this.
Sonali, I think even the WHO has defined infertility now as a disease. So when it is put in a category of disease, I think it should come under the Ayushman Bharat scheme, because as our Prime Minister wants to, treat everybody, those who cannot afford the treatment. So it should be included. And another thing that I feel along with Ayushman Bharat is also that if they can give a kind of a mediclaim to these people also, because it is a disease finally. So Ayushman Bharat will cover the people who cannot afford it, and the government will pay for it, and Mediclaim will probably help those who would want to do it but would like to do it in kind of a little bit of steps which will assist them. So I think this is something that we should promote for the patients.
Fine. So thank you all. Thanks for joining today, and thank you for giving your time and talking in detail about the provisions. Thank you so much.
Thank you.
Thank you.
Thank you.
Thank you everyone for delving deeper into the discussion and for all the knowledge around the ART will transform the IVF segment. Let's proceed further. Stay tuned everyone.